Hello everyone, very good afternoon to all of them present here. Dhwani, am I audible?
Yes, you're audible. Hi, everybody.
Hello. So, first of all, happy Dashera to all the participants who have joined the meet on this holiday, taking out time to attend the demo class, showing so much of sincerity towards oral surgery. And with this, I'll also welcome Dr. Dhwani Kawadkar, who has been my batchmate since my undergraduate time. And now on this masterclass 1.0 she'll be dealing with oral surgery for the next coming 2.5 months for all the students who are going to opt for this course, right? So this is a demo lecture where she'll be explaining about a topic, any one topic, and wherein you can ask your doubts and queries also after the lecture has ended. And apart from that, if you guys have any queries regarding masterclass 1.0, like what is the timing of the class, how are the class going to be conducted, so everything you can ask us in the chat box also, and you can ping us on WhatsApp or you can give a call on our number. So apart from that, as I can see, we have around 10 to 12 participants in the meet. So I just want a thumbs up or a sign so that I can know you all guys are there in the meet and attentive so that we can start with our lecture. So everyone can just show a thumbs up in the chat box so that we can start once we have got confirmation from all of you. Yes, I am receiving Sandhya, Anjali, Huda. Okay, so
That's
yeah, most of them are there. So now I'll hand over the platform to Dr. Dhwani where she'll start with her lecture. Platform is yours, Dr. Dhwani.
Thank you, Dhrumal. Okay, so I am Dr. Dhwani Kawarkar, oral and maxillofacial surgeon, which is a big deal. Also, it's I know most of you have this dream and fascination for oral surgery as well, but sometimes we face problems in our undergraduate days, which makes it a bit scary. Okay, so our aim at DTTP is to organize all the topics such that it becomes easier for you to understand. Okay, so before you go on competitive level ki MDS karna hai, we want to simplify the topics so that you have a better understanding of the basics. Okay, so that is more important, trust me, because when you prepare for your post graduation or you go in your private practice after your BDS, basics should be clear. Why? Because they make your understanding, your problem handling as a doctor easier. Okay, so today I am going to cover the most basic topic. Why I am covering this topic today is so that you're more versed with this topic, so you can understand it easily and get a point of view what DTTV targets at. Okay, so today I am starting with impaction. Okay, so let's start with our presentation and we'll talk in detail. Okay, so I hope you guys are able to see my screen. I have shared my screen. Drumel, is it visible?
Yeah, Dhwani, the screen is visible.
Okay, great. So today, what I told you that we are starting with impaction, but here you can see mandibular impaction. Why? Because the most common form of impaction seen in humans is mandibular molar impaction. Okay, so we'll deal with this first. This is the most important of impactions. There are other impactions. Chronologically, if you speak, mandibular impaction is first, then is maxillary impaction, then maxillary canine, and so on and so forth. Okay, so when you start studying impaction, the one that you will study the most in detail will be mandibular impaction. So today we will be discussing that. Okay, and if you guys have any query, you can stop. You please don't stop. It's a request. Please don't stop me in the lecture. You can drop your questions in the message box, and in the end, we can discuss it all. Okay. In the end, you will have all the time to discuss your doubts. It will be better if you sit with a pen and a paper, for better understanding for queries. Okay, so extra edge. Let's talk about this. something extra that you might know other than your books. Okay, so the development of mandibular third molar starts at the age of 7 years. The first radiological sign is present at the age of 9 years. Cusp mineralization is completed at 11 years. Crown completion at 14, 50% root at 16, root completion with open apex is 18, and it comes to its complete occlusal relationship at the age of 20. Now you will see some patients who don't have any occlusal relationship. Okay, so why is that? Because there is some hindrance in coming to its normal occlusal level. It could be because of soft tissue. You know, thick soft tissue can also cause impaction, or there can be bony hindrance as well. Okay. Now there are various theories why third molar is mostly impacted. We'll come to that later. Okay. And one more thing, one extra thing I would like to tell you is, you know, a patient, 16-year-old patient comes to you and he's complaining of third molar pain. So you have to have a treatment plan always, right? You're a doctor, you're going to be doctors. So at the age of 16, you can't go ahead and extract the tooth straight up. You have to wait for some years, they say. Now, why? This is the reason. Because the complete occlusal relationship will come at 20 years. At the age of 16 years, it might not have erupted. Now, the second thing is the easiest time to remove a third molar. You know, you can diagnose it ki, okay, this tooth is never going to come in occlusal relationship and you have to remove it. That, so the easiest time is when the root is 2/3 complete. Okay. Now, we'll be discussing this presentation under these headings, okay? Introduction, etiology, theories, classification, indication, contraindication, pre-surgical assessment, surgical techniques, outcomes, okay? Now, why this is important is, in your from your exam perspective, whenever you write an answer, writing it heading wise is most important. So these will be your headings. Introduction, as you can see, word impaction is derived from Latin word impactus. An impacted tooth is one that is completely or partially unerupted and is positioned against a physical barrier, which can be bone, soft tissue, or a combination. Now, natural development of third molar. During the mineralization of permanent molars, a distal extension of dental lamina is seen. We have read in oral pathology, DADH, what a dental lamina is. Okay. So permanent molars are what? They are a distal extension of the dental lamina itself. A bony groove is created due to bone resorption, thus forming a partial tooth socket or the third molar tooth bud to develop. Can you imagine what is happening there? There is a resorption of bone and a pocket-like place is formed, which is a partial tooth socket. The eruption starts when the cervical part of the root is formed. The tooth germ starts to move away from the mandibular canal, assuming a distally curved eruption path. Okay. Changes in the direction of eruption will also lead to deflection of the roots. So this is a bit of anatomy, that what kind of root will be formed, what will be the path of eruption. It is not so important from your exam perspective, just for your understanding. Okay. I'll tell you which parts are important for your exams as well, or your understanding clinical practice. So this is important. Okay, local causes of impaction. What can be those? Irregularity in the position and pressure of an adjacent tooth, density of overlying or surrounding bone. Some people have more dense bone, so their impaction will be more. Chronic inflammation. Chronic inflammation causes fibrosis at a place, okay, in your whole body. So if there is fibrosis, there will be thick fibers. It will avoid eruption. Underdeveloped jaws. The jaws are, smaller, like एंडी गम फेस, टीएमजे एंकाइलोसिस में एंडी गम फेस आपने कहीं ना कहीं देखा होगा. So एंडी गम फेस person will have a smaller mandible, really small. So what will happen? Underdeveloped jaw, there is no space for third molar to erupt. Now next will be retained or premature loss of primary teeth. This is very important. That's why pediatrics is also a very important branch and an upcoming branch right now. The उसका जितना भी अंडरस्टैंडिंग ऑफ प्रीमेच्योर लॉस रहेगा, ये सब these are important. Okay, acquired diseases, obstructions like thick scar band, odontogenic cyst, tumors. Now there are the other causes. Causes of impaction are divided into two: local causes and systemic causes. Now systemic causes सबसे ज़्यादा important and common is always heredity. Okay, hereditary affects all your teeth, all your jaw size, and other features. Postnatal cause can be rickets, anemia, congenital syphilis, tuberculosis, endocrine dysfunction, malnutrition. Anything and everything that affects your bone, your jaws, your soft tissue can affect impaction, can cause impaction. Now, rare condition will be cleidocranial dysostosis, progeria, cleft palate. Progeria is what? Have you seen that movie? Amitabh Bachchan, he's aging too fast. His age is 12, 13 years old, but he's aging too fast for his age. That is progeria. Okay. Cleidocranial dysostosis is a bony disorder which affects your clavicle, your cranial bones, and your facial bones. Coming to next one. Now theories I was talking about, okay, this is like three star important. Okay, I usually discuss my important topics for exam in form of stars. So there's 1 star, 2 star, 3 star. If I'm telling you 3 star, it is really important. Okay, so first of all, coming to the names: the phylogenic theory, the Mendelian theory, endocrine theory, the pathological theory, and the skeletal or orthodontic theory. There are 5 theories. Okay. Coming to the phylogenic theory, its use makes the organ develop better while disuse causes it slow. You all might have seen disuse theory. What is it? The part of body which is not used much will slowly regress. Okay, and the part that is used more will develop. Like आजकल बोलते हैं ना, लोग अपना दिमाग नहीं यूज कर रहे हैं, so वो भी छोटा हो रहा है. So that is what is phylogenic theory in short. Next is the Mendelian theory. Heredity is the most common cause here. The hereditary transmission of small jaw and large teeth from parents to, sorry, it's written siblings, it should be offsprings. This may be important etiological factor in the occurrence of impaction. Okay, so we all know how in our 11th and 12th grade science we have read how heredity works. You get one chromosome from your father and the other from your mother, and that's how a pair is formed. Okay, so what happens is, from my mother I got small jaw. Okay, the chromosome for small jaw, and from my father I got a chromosome for larger teeth. So obviously there will be less space. That is what is the Mendelian theory. Coming to endocrine theory, so due to lack of function of anterior lobe of pituitary gland, insufficient growth hormone comes from anterior lobe of pituitary gland. Okay, growth hormone is less, so lack of growth of jaws, less space for third molars. Simple, easy. Endocrine theory matlab hormone related. Next is the pathological theory. Chronic infections, as we discussed, will cause condensation of osseous tissue, dense fibrosis, and habits like mouth breathing. What will these do? Constriction of dental arch and further prevent the growth and development of jaw. The last one is the skeletal or orthodontic theory. Improper function of the functional matrix, inadequate growth of the jaws, lack of space for the eruption of third molars. Matlab, it is basically a modification of Mendelian theory that we read. Okay. So the most accepted one right now, okay, one more point. The most accepted one right now is the skeletal or orthodontic theory. But you have to remember all 5 names. Okay. Coming to classification. Classification, you have to remember another important thing from your Viva perspective as well and your theory exam as well. ठीक है. अंडरस्टैंडिंग, जितना यू विल प्रैक्टिस, जितना यू विल लुक एट ओपीजीज, जितना यू विल लुक एट इम्पैक्टेड आईओपीएस, you will understand it more. Okay, visualization is the key here. I can tell you this, but you have to go see in the OPGs and IOPAs and guess. Okay, you can do that. You can just guess ki, okay, this looks like mesioangular, this looks like distoangular. You can go bug your seniors, you can go bug your teachers, and then you will understand it very clearly. Once you have the visualization, it is very easy. Okay, so the first and most common one used right now is Winter's classification given in 1926. What he did was, long axis of the third molar and long axis of second molar, he compared these two. Okay, second molar is usually erupted, so he compared third molar with that. उसमें जो, however the name is now, imagine second molar is a straight line and the third molar's position is exactly the word that we are using. Okay, so if I say vertical, so third molar is vertical to second molar. Okay, if I am saying mesioangular, so it is mesioangular to second molar. So these are the seven. I don't have to tell you the name, I just have to help you imagine what we are talking about. Okay, so these are the seven names. Now the next one is Pelon Gregory classification. Again, very important. And this you can mostly visualize in an OPG only. It's a bit tough in IOP. Okay. So according to relation of the tooth to the ramus of mandible and the second molar, horizontal plane, there are class 1, class 2, class 3. Okay. Class 1 is what? You can see the first image. There is sufficient distance, sufficient space present between second molar and the ramus of mandible. Okay. Now, अब बहुत सारा स्पेस नहीं है, ठीक ठाक स्पेस है, मीडियम स्पेस है, दैट इज द सेकेंड इमेज. सो दैट विल बी क्लास 2 कि there is space present but not enough for third molar to completely erupt. That will be class 2. In class 3, the complete tooth is embedded in ramus of mandible. There is no space at all for it to erupt. Okay, it is in bone only, completely in bone. That is class 3 according to Pelon Gregory classification. Now there is one more component. Pelon Gregory classification is made of two components. One is this one that we have seen, class 1, 2, 3, and the other is position A, B and C. Now what are these? According to the relative depth of the third molar in bone, that is vertical plane, position A will be the highest portion of the tooth is on a level with or above the occlusal line. Okay, look at the first picture. The occlusal plane of third molar is equal to the occlusal plane of second molar, right? So that will be your position A. Now come to image 2. Occlusal plane of third molar is in between the occlusal and cervical plane of second molar. मतलब crown को देखो second molar के, उस crown के बीच में होता है occlusal level third molar का. तो तब वो होगा क्या? पोजीशन बी. पोजीशन सी मीन्स सर्वाइकल रीजन जो है सेकेंड मोलर का, कम टू दैट, उसके नीचे है ऑक्लूजन लेवल थर्ड मोलर का. अंडरस्टूड? थोड़ा सा टफ पड़ेगा बट इफ यू सी द डायग्राम्स तो यू विल अंडरस्टैंड मोर. अनदर थिंग, any answer that you write in your exam has to have diagram. It has to have diagrams. Okay, so these diagrams in my presentations are for your understanding and for your better answer writing purpose as well. Now the third one is Killian case classification. Not so important for you, but okay, you can look at it once. State of eruption is erupted, partially erupted, unerupted. Number and pattern of roots are fused, true, multiple, favorable, unfavorable. Okay, and the first point will be Winter's classification only. So three components here. ADA code on procedures and nomenclatures describes the amount of soft and hard tissue over the coronal surface of an impacted tooth. Soft tissue impactions, complete bony impaction, partial bony impactions. Again, you can look at this numbering. These numbers that you can see here are the terminologies given by ADA, but not commonly used in practice. You can just have a look at it. Now, coming to indications for removal. we discussed earlier in our presentation that not always, if a 16-year-old comes to you with pain in third molar region, and you can see that that tooth is and pressure from third molar is causing them pain, you can't straight up just go ahead and remove it. Okay, you have to have certain indications for it. Okay, and contraindications are also there, but here we are discussing indications. First and foremost, most commonly that you will see is pericoronitis. Okay, pericoronitis is what? The flap, the soft tissue flap that covers our third molar will always have some food impacted and bacterial impaction because it's a loose flap. It will cause pericoronitis. Okay, and so usually the protocol followed is कि first time the patient comes with pain due to pericoronitis, we go for conservative treatment like medication, deep scaling, and removal of coronal flap. We do that. Okay, but if the pain keeps persisting or pericoronitis is persistent, we go for tooth removal, complete tooth removal. In the first go itself, we don't usually prefer it. Second is dental caries, deep dental caries, or prevention of dental caries. Sometimes, because of the position of your third molar, your second molar is also compromised. It can also have dental caries, so you have to see to that. Periodontal diseases or its prevention, anything that has severe periodontitis has to be removed. There is no saving it if it is in severe forms, and there is no point in saving third molar in periodontal diseases. Prevention of root resorption of what? Your second molar, because if it is applying pressure to your second molar, there will be resorption. Odontogenic cysts and tumors, pain of unexplained origin like TMJ, pain of unexplained origin, patient's informed refusal of non-surgical treatment. As I said, in pericoronitis, we first go for conservative treatment. But if your patient is like, no, 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 I have a lot of pain, I want it removed only. So you have to get a consent and remove it. Next is fracture of the jaw or tooth in the line of fracture. It is called line of fire. Okay, again an extra bit. Line of fire is when a tooth lies in the line of fracture. So you have to remove that tooth if the tooth is in fractured line. Prosthetic problems, that is the patient has to get some prosthesis where it is required. Orthodontic relapse or facilitation of tooth movement for orthodontic treatment. Tooth interfering with orthognathic and or reconstructive surgery. Whenever a patient has to undergo orthognathic surgery, the third molar removal is indicated 2 to 3 months prior to any surgery. Okay. Now coming to contraindications. Extremes of age, a very young patient or a very old patient. Compromised medical status like uncontrolled diabetes. There can be a controlled diabetic as well where we can remove it. But whenever it is uncontrolled diabetes, ठीक है, severely hypertensive patient, severe anxiety, all these things are contraindications. You have to check complete medical status of your patient. You remember first, second, third year, maybe we used to have fight with our medical colleagues that we study all the subjects that you study, still you call us dentist, we are not doctors and all those things. Be proud to be a dentist because you are going to treat the teeth as well, and you are going to basically look at their complete medical picture as well. Here is where those subjects and those hardships come in play. You have to check the complete medical status. Okay. Then excessive risk of damage to adjacent structures like inferior alveolar nerve when the future status of the second molar is questionable. In those cases, third molar will take its place. Uncontrolled active pericoronal infection. We discussed already that you have to first control it with antibiotics, scaling, and then go for extraction. Or buccal position of upper third molar. Now, okay, so treatment planning. What is treatment planning? You have to look into all the aspects of a treatment. Okay, the pros and the cons of treatment, how it will be done, if there are any other medical history related. So that treatment planning can only be done with pre-operative assessment. You have to assess first, right? So in 3 points you do assessment in case of third molars: history, clinical assessment, radiological assessment. Clinical factors affecting removal of impacted third molar. Okay, you can just have a look at it. This is not very important. You can just go through it once. Mouth opening, tongue size, tooth status, attrition, bone status. Okay, so where removal is easy, where removal is difficult. It is a very common sense wala topic, but not very important. Now, radiographic assessment is important because there are 2-3 questions which are very commonly asked, especially in Viva and sometimes in your theory short questions. Okay, I'll come to that. Axis determined by noting the inclination of the radiopaque line cast by the external oblique ridge. If this line is vertical, axis is poor, while if it is horizontal, axis is excellent. The axis that we are talking about is the axis to the third molar tooth when it is impacted. Position and depth. This can be assessed by taking intraoral X-ray or even lateral extraoral X-ray. So this is the question that is most important for your Viva, and sometimes it is asked in your short questions. Okay. So again, the diagrammatic part is important here. There are 3 imaginary lines that are drawn for radiological assessment. Matlab, you take an X-ray of the impacted tooth. On that, you are drawing some lines and assessing that this extraction will be easy or tough. You're pre-planning the case. Okay, you're not going in and starting blindly. You're pre-planning it. So there are 3 lines: white line, amber line, red line. We call them war lines or winter's lines. So what is white line? It is drawn along the occlusal surface of the erupted mandibular molar and extended posteriorly over third molar region. It corresponds to the occlusal and the axial inclination of the impacted tooth, which becomes apparent. Look at the diagram, you will see the dashed line, you can see, right? White and black, white and black. So what you do is, erupted mandibular molar जो भी है, which is mostly second molar, you start from its occlusal surface and extend it posteriorly over the third molar region, and this will give you what? The axial inclination, the inclination of the axis, and the axial relationship with the second molar. Okay, now coming to amber line. So this is the line that is drawn from the surface of bone lying distally to the third molar to the crest of the interdental septum between the first and second mandibular molars, and it represents the bone level. You can see the dashed line in the diagram, dash 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 wali. So that is what is the amber line. Posteriorly से start करेंगे bone से, and it is extended to the interdental septum till the first and second molar. Okay. So कितना bone cover कर रहा है third molar को, that is indicated through amber line. Now what is red line? It is a perpendicular that is dropped from amber line to imaginary point of application of an elevator. You all know what an elevator is. We use it to elevate the tooth out of its socket. So you imagine a point where you can, put your elevator and elevate the tooth, and you drop a perpendicular from amber line. That gives you the red line. And this is important. With 1 mm increase in the length of red line, extraction becomes 3 times more difficult. Root pattern, we discussed earlier that there are different root patterns in the tooth. So root pattern also affects the removal of impacted third molar. Like if it is fused, obviously the extraction will be tougher. If it is a single root, it will be easier. Okay, it can get elevated easily. Straight, favorably or unfavorably curved. Favorably means the path of removal has favor from the root, and there are other examples. Now, shape of crown. Teeth with large crowns and prominent cusps are more difficult to remove than teeth with small conical crowns and flat cusps. When tooth impaction is present, the cusp of the third molars are superimposed upon the distal surface of the second molar in the radiograph. Large bulbous crown with prominent cusp is difficult to remove. Texture of the investing bone. Okay, so investing bone matlab surrounding the crown. The bone surrounding the crown, including the interdental bone in case of multiple roots. It can be determined by radiograph only if the standard procedure is followed. This varies between individuals and with age and site of the same individual. In children, the bone is a bit softer, it will be easier. In young adults, the bone is really stiff and tough, it will be tougher. Okay, so like that we are talking. Bone becomes more sclerosed and less elastic as age advances. If the cancellous spaces are large and the bone structure fine, the bone is elastic. Now position and root pattern of the second molar. Distal tilt of the long axis of the second molar creates or increases tooth impaction of the buried teeth. Then we come to existing pathology, dental caries, periodontal disturbances, presence or absence of first molar, fusion of crown between second and third molar, conical and fused roots of second and third molars, or any other associated pathology. All these points that we are discussing are the points that affect our assessment, that will affect the extraction and comes under assessment, pre-assessment. Okay. Now, relationship of root canal of root of the impacted molar to the inferior alveolar nerve canal, related but not involving the canal. Okay, it is in the first image you can see, and the second it appears to be overlapping IN, but it is not overlapping. It is just in relation. Second is related to changes in the roots, darkening of the root, dark and bifid root, narrowing of the root, and deflected root. Okay, relationship. Then the third point is related to changes in the canal. So here they are changing the anatomy of canal itself, interruption of lines, converging canal, or diverted canal. Warface assessment. So you will find a chart that is given in your books. Okay, so that chart you have to remember. So why? Because there is nothing to explain in that. You just have to see what are the scoring given to which tooth, which type of tooth, and then you have to remember that. It is also very, very important. Okay, you will get one question asked from this whenever impaction comes, either in your theory or your viva. So Warface assessment is what? It gives you an assessment of how tough the extraction is. Okay. So in horizontal, in angulation of third molar, if the angulation is 1 to 50 degrees, it is 0, 60 to 69 1, 70 to 79 2, and so on. Okay. Then the next factor is height of mandible. If 1 to 30 mm is the height of mandible, you give a score of 0. If it is between 31 to 34 mm, you give a score of 1, and 35 to 39 mm, you give a score of 2. Then the third factor is Winter's classification. You remember horizontal, vertical, that way. So if the tooth is horizontally impacted, you give a score of 2. If the tooth is distoangularly impacted, you give a score of 2. And if mesioangular, then 1. And then these scores are accumulated to give you a final score. Okay, so these are again three things that are included. The fourth is space available is 0, distal cusp covered is 1, and so on and so forth. Coming to follicles, if the follicle is normal, 0, possibly enlarged, 1, enlarged, 2. Now root shape is also a factor, complex, 1, unfavorable, 2, unfavorable curvature, 3. ठीक है. So now what we do, we score all the tooth in the uh, under those 6 headings. Okay, and then we add all the scores and get a final score. So if a score, the total score is between 15 to 16, the extraction will be very difficult. If the score is between 7 to 8, it will be moderately difficult. If it is between 0 to 6, it is minimally difficult. Why I'm not going into the details of it is a scoring chart, so the headings you will have to remember. Okay, but I explained how it works. The same way, there is another scale which is Peterson's difficulty index. Okay, Warface is used more commonly because it has more factors. It considers more uh, various factors. Okay, it has 6 factors, and here in index, you have angulation, you have depth, and you have Ramus relationship. You again get the total score, and according to that you have a very difficult extraction, a moderately difficult extraction, and a minimally difficult extraction. Now coming to the most important part, clinically. Okay, you can get questions asked viva may and everything, but treatment is most important. How clinically going to become doctors in practice, so treatment plan is most important. Now, as I was talking to you about ages, you can't just go ahead and have a treatment plan for any age and have a uniform treatment plan for every age. It is different for all age groups. So first one we are talking about is age 15 to 19 years. At this stage, third molars are ready to be auto transplanted, and the usual site for transplantation is mandibular first molar region. What happens is, in some cases, first molar is extracted in their younger age, or the first molar is congenitally missing, or some other reason. You need first molar के बिना occlusion is very poor. Okay, it depends on your occlusion and occlusal relationship of first molar. So the third molar can be used for auto transplantation and can be transplanted to first molar region. Coming to age 18 to 21 years. Ideal time for final decision. At this stage, eruption status of the third molar can be categorized as fully erupted, semi-erupted, or impacted. Now coming to fully erupted. Indications for removal is due to lack of an antagonist, caries, or other factors. Just a second, I am having a glitch. Just a second, my laptop has stopped responding. I'll get back in a minute.
Hello. Yes, good afternoon, participants. There is some technical glitch on the tutor side. She'll be back in a minute. Till the time, I'll just announce one thing which we have for all the candidates who have shown their interest to attend the demo lecture, right? So, specifically for all the candidates who are here in the Google Meet, I'll share a payment link in the chat box at the end of the class, and that will be a special discounted offer for all of you candidates, right? So instead of 1349 for the subject, you can choose the subject and opt it for 1200 rupees only. So that is a straight away discounted offer for only you all. It is not going to be generalized for all the students, right? So the link will be active for only half an hour to maximum 45 minutes. So if you are going to register in that time frame, right, that is within the time frame of that 30 to 45 minutes, you can get this subject in 1200 by Dr. Dhwani Kawadkar, right? And apart from that, once if you have done the payment, what you can do is you can just take a screenshot and just send that screenshot on my number on WhatsApp, so that we can just confirm your registration and get you on board with us for the further registration procedures, right? And apart from that, if you guys are having still any doubt, all the participants who are having any doubts regarding the masterclass 1.0, you can just type it in the chat box, anything which you want to ask. I am here to answer your doubts and queries, right? So feel free to ask anything if you want. Don't feel shy. Okay, we are not someone like your staffs. We don't want a college kind of environment over here, right? That is the main difference which we want to create over here. That is, there is a lot of difference when we actually attend a class or a lecture in our college, right? The professor comes and speaks for an hour and he just goes off, right? That is happening in most of the colleges. I'm not saying that all the colleges will be having that format. There might be institutions and colleges where the staffs and the teachers are very well interactive with the students and having a friendly nature. So that is the first aim of our venture, right? So we want one-on-one discussion, or one on how many of our students are there in the class, so that we can discuss openly. You can ask anything. You can ask a silliest question and we'll have a solution for that also, and you can ask the toughest one what you have got in your mind, right? So it's going to be a free platform for all of you who are interested in joining this masterclass 1.0, right? So feel free to ask the doubts to all the faculties, right? Instead of just staying quiet in the Google Meet, right? You need to have a better communication skill as a dentist, I would say, because there is a lot of competition right now. If you see, every 500 meters you have a clinic or more than one clinic also, right? And sooner or later you all will be ending up in that phase after you complete your BDS, or you're going to go for post graduation, or some of you might go to abroad to different countries to pursue their higher educations also, right? So wherever you go, communication skills is going to play a major role in your curriculum and your practice. If you are going to be an academician, a clinician, or whatever you are. Yeah, we have Dhwani back.
Yes, hi. Sorry, it was a major glitch. Let's resume.
Yeah, no issues.
Yes, hi. I genuinely hate computers. So sorry for the glitch. Okay, so let's resume. So we had talked about the age group. Now the partially erupted tooth. Tooth is removed due to repetitive attacks of pericoronitis. As I explained to you early on, the first time the patient comes with a complaint of pericoronitis associated with third molar, you don't go for removal directly. You give your conservative treatment and then you wait. Why? Because sometimes the third molar is more important, saving it is more important than its removal. Okay, you always have to balance your pros and cons. So next one is impacted. Indication for removal are enlarged follicle with or without signs of infection, close proximity to the gingival crevice of second molar, and the third is initial or progressive marginal periodontitis of second molar. Now, age 22 to 25 years, indications of removal are caries, deep caries, or caries that are associated with second molar caused by position of third molar, pericoronitis, gingival inflammation, and marginal bone breakdown. After 35, after the age of 25 years, if a patient is coming to you, careful cost benefit ratio should be evaluated. Okay. Now, surgical techniques. There are different surgical techniques. The most common one that you might have observed in your hospitals or clinics or your postings is when you use a straight handpiece, a burr technique. So, we will come to that as well later on. But in the first go, we are discussing an atraumatic removal. Okay. Principles basically are where you have to see these things are followed. Okay, whatever your technique is, these principles have to be followed. The first one is atraumatic removal. You have to cause minimal trauma to soft tissues, to hard tissues, and in general. The second one is with minimal or no interference with adjacent anatomic structures like inferior alveolar nerve, external oblique ridge, other tooth. Then the optimal chance of uncomplicated socket healing represents an optimal goal. We don't want necrosis in our tooth socket. We don't want exaggerated bleeding from our socket. We don't want dry socket in the socket. So that is also very important in third molar removal. Basic instruments that are used are, you don't have to see this, I'll show you a picture. Okay, that way you will see more. What? Okay, let's go through this once quickly. Cheek retractor you have to use for visualization. Incision के लिए हमें क्या चाहिए रहेगा? BP blade and number 15 blade. In your basics you have studied the numbers of blade, so here we use number 15 blade. Flap development and reflection. Moon's probe, Howard's periostal elevator. मून्स प्रोब आप अपने क्लिनिक में जाके एक बार पूछ सकते हैं व्हाट इज अ मून प्रोब. इट्स अ वेरी पॉइंटी, जो हम नॉर्मल यूजुअली डायग्नोस्टिक्स में यूज करते हैं वैसे ही होता है, जस्ट अ बिट डिफरेंट. ओके, फ्लैटर एंड, इट हैज अ फ्लैटर एंड. देन फ्लैप रिट्रैक्शन के लिए कौन सा रिट्रैक्टर यूज होता है? जनरल सर्जरी में यू माइट हैव रेड L retractors, okay, Doyle's retractor. Here the retractor uses Austin's retractor. I'll show you the picture. For bone removal, you need handpiece, burr, or chisel, depending on which technique you're using. Luxation, elevators, tooth removal के लिए forceps, and suturing के लिए you obviously need sutures and needle holder. So this is your complete picture of what all you will need. Top right end, you can see the cheek retractor. Top left end, all types of elevators. Okay, in the middle, you can see a bone ronger, a suction toothpick. जो सक्शन टूथपिक दिख रही है सबको, उसके जस्ट नीचे द इंस्ट्रूमेंट केप्ट इज चिजल. ओके, चिजल मैलेट इज व्हाट, हिंदी में मैं बोलूं तो छेनी हथौड़ा. इफ यू नो, द कारपेंटर्स एंड द कंस्ट्रक्शन वर्कर्स दे यूज इट. It's similar to that but medical grade. Okay, so chisel, you put it on a bone and with a mallet or the hammer like instrument you give it light taps. Okay, very light taps, so it separates out the bone. But it's a very old, it's a not very old, but it's an older technique, not very commonly used now because of you know, the difficulty of handling, and it can cause more trauma. That's why. So you have to use less traumatic instruments. Gauze piece, kidney tray, diagnostic instruments, BP blade, periostal elevator. Okay, so on the right side of periostal elevator, there's a longer and more sleek elevator that you might or might not have seen. It's called Howard's elevator. It has similar function to periostal one but more comfortable. Then the scissor, then Ellie's curved artery forceps, and then there is tooth, non-tooth forceps, there is needle holder, there are sutures and suture cutting scissors. So steps in removal are isolation, anesthesia, incision and flap design, bone removal, sectioning or division of tooth, elevation and extraction of tooth, debridement and smoothing of bone, control of bleeding, flap repositioning and suturing, and follow up. Okay, one thing that we are missing here is medication. Post-operative medication has to be according to the case. Okay, if you have done a more traumatic case, you have to give better antibiotics. You have to give better analgesic and anti-inflammatory. Okay. So, okay, one more thing that I have to point out in my presentation is everything that we are doing or learning here is point wise. It has headings, it has points. That's how your theory exam should look like, your theory paper. Nobody cares if you have written paragraphs and paragraphs. Okay, they just want to have a look all at the headings, the diagrams, the flow charts. So isolation is scrubbing and painting of skin and oral mucosa with most commonly povidone iodine. Other substances can also be used, and then draping the patient with sterile drapes. This is preparation called as painting and draping. Incision and flap depends on your tooth position. जो हमने पहले assessment किया था, right? Preoperative assessment. Depending on that, your incision is planned and your flap design is planned. Principles: flap consisting mucosa and periosteum, not just mucosa but periosteum as well. Design large enough to provide adequate space. Viability: the base should be broader and the top should be narrower for proper blood supply. Then healing: line of incision should be placed on sound bone, not necrosed or compromised bone. So there's a saying in surgery that your complete operation, any surgery, your complete operation depends on your first incision. Okay, so always remember that, doctors. Your incision should be correct. It should be pre-planned, and that will decide your complete outcome. Why? Incision छोटा होगा, you won't have better access. Struggle करते रहोगे for extracting the tooth. Okay, if your incision is decent, it will give you enough and good access. If your incision is too long, healing will take longer and it will create more problem than cure. Now standard, there are two types of incision used in third molar impaction: Ward's incision and modified Ward's incision. So Ward's incision I'm talking about first is, what happens is, third molar is not that deeply impacted. So what you do is, the anterior releasing incision is between the second and third molar. Okay, because you don't have to go very deep in bone. The some part of crown is visible of third molar. But I'm just giving you a comparison. Okay, we don't have a picture of modified wards, but okay, I'll give you a, thoda sa overview of it. Up, imagine in this picture only, your third molar is very deeply impacted. Okay, so if you give an incision between imaginary third and second molar, as you can see here, what will happen? You won't have enough access to the third molar. You will end up retracting your soft tissue a lot, damaging it a lot, more than required. We don't need that. Minimal damage. So what you do is, this incision is extended between first and second molar. So you have more access towards the back. That is what is modified Ward's incision. Now, other types of flaps, you can just remember the name and look at the diagram once. The first is envelope flap. How an envelope looks, it does not have an anterior releasing incision. Then the second molar and first molar sulcus incision flap, again called as envelope flap. Then there is bayonet flap. Then there is second molar or paramarginal flap, and then lingual flap. Lingual flap is the least commonly used one. Why? Because lingual side पे आ जाती है lingual nerve, which has to be protected anyhow. Okay. Now flap elevation and retraction begins either entirely at the start of the incision or at the vestibular extension. मतलब simple सी बात है, जो हमने vestibule में extension दिया है, we are using that area to elevate the flap. Okay, and you have to retract it using the bayonet, using the Austin's retractor that I talked about. Now, for bone removal, the whole point of this impaction is the removal of bone covering the third molar. So there are two most commonly used techniques. I'm sorry if there is some disturbance. People are in, holiday spirit. So if you cannot hear me, please let me know. I'm continuing with the presentation. Okay. So there are two techniques: burl technique, chisel technique. I just told you what chisel and mallet are. So imagine chisel and mallet. Bone को remove करने के लिए you are placing your chisel at the decided point, and then using mallet to lightly tap it. Okay, and then you remove the extra bone. But if not controlled, it can cause even mandible fracture. So it is a very technique sensitive thing. So now most commonly used one that you might have observed in your everyday practice is burr technique. Okay, what we use is a straight burr, a carbide burr or a diamond burr, because they are easier to use on bone. And you use a straight handpiece and motor, and you what you do is remove extra bone. Remember, the bone removed should not be very excess. It should be जितना required है उतना ही. Why? Because we want quick healing, minimal damage. So burr technique is what? Nothing but removal of extra bone. Now, this is the most common one used by us maxillofacial surgeons and in clinics. It's called Moore-Gilby collar technique. You know what collar is, right? So, what you do is collar-like removal of bone. Minimal bone is removed around the tooth till CEJ. Okay, so till CEJ, if you remove the bone, the elevator can be placed in the CEJ and the tooth can be elevated. Okay, in the distal end you don't cross the midline of crown. Okay, so imagine distally you have divided your crown into 1/3, 2/3 and lingual third. So buccal third तक के ही हमारा जो bone removal है वो वहीं तक के होता है. We don't extend it because there we have a chance of damaging the lingual nerve, which we don't want. So here we come image mem. Okay, so we are using BP blade and BP handle and blade number 15 for our incision. The first image you can see, sorry, the first image you can see the backward extension. That is the backward extension which is kept a bit buccal. Okay, never go lingual, we keep it buccal. And then the releasing incision that is going in the lingual, in the buccal vestibule. Okay, you can see it here clinically. And here you can see that we have not extended it till IAN. We protect the IAN at all costs. Okay, the same thing, but here you can see periosteal mucus and periosteum flap is removed, and you can see the a part of crown visible with surrounding bone, right, like this. So what we do is, इसका जो cervical area दिख रहा है वहाँ पे crown में, crown के around we do a collar technique using burr. Collar like guttering करेंगे, bone removal or guttering, and then we remove the tooth, we elevate the tooth. Okay, so here we are first using a round burr in the first image. You can see to mark the area that has to be removed, and then we are using a straight burr. Okay, to create a collar. You can see a ditch. See, a bone guttering of equal width is done around the tooth. And then the elevator is placed mesially. It elevates the root socket. There is a path of removal. इसमें path of removal is very evident कि okay, medially you have to engage your elevator and lift it. It will come out easily. If it is getting engaged somewhere, then we have to split the tooth as well. Okay, sometimes you have to split the tooth as well. Now, what is this soft tissue? The granulation tissue. There was infection, right? So there might be some granulation tissue. So you have to clean out your sockets with your you have to clean out your sockets completely, irrigate it completely, and you saw bone ronger and bone files as well. You have seen, right? So the sharp ends, you are using a burr, so there might be sharp ends. So you have to remove all those sharp ends. Otherwise, it will cause trauma to the soft tissue. And then you see the suturing. Suturing should be what? Watertight. Watertight meaning there should not be any oozing out of soft tissue or blood from the socket. Split bone technique, you split the bone. Quick and clean technique. Advantages are reduce the size of the residual blood clot by means of saucerization of bone. Disadvantage, only suitable for use in young patient with elastic bone. Slight increase in incident of transient lingual anesthesia. Okay, this is the image, and as I told you, chisel and mallet is used here to split the bone at definite places. The removal of a tooth impacted mandibular third molar using tooth division. I just told you that we remove the tooth by an elevator. But sometimes the path of removal, you see these arrows, these are the path of removals. But as you can see, the second molar is in its path. Okay, मतलब physically block कर देता है कई बार. So what you have to do is you have to section your tooth, you have to cut your tooth. So that's what we are learning here. In the first image, you can see the tooth has been cut horizontally, and here in the second image it has been cut vertically to my vision, not to the tooth axis. Okay, so these are some more images of removal of tooth using the burr technique. You can see the last image, only root piece you can see. What we did was we removed the in the figure D, we are sectioning the crown. Okay, and the crown is removed differently, and then the remaining root piece is removed. The same images you can see here, the tooth has been split, and then a part of tooth is removed first and then the other part, because यहाँ पे hindrance was not caused by second molar, it was caused by the ramus of mandible. Delivery of tooth, if sufficient force is applied by means of an elevator to the mesial surface of the tooth impacted lower third molar, the tooth will rotate in an arc, and the center being at the apex of the distal root. Okay, one more thing clinically, whenever you are applying an elevator, obviously you are using a lot of force, and TMJ is a sensitive joint when a lot of force is applied on mandible. So whenever you are applying an elevator in the mandible, make sure that you support the mandible so that TMJ dislocation doesn't become a complication for you. Okay. So these are not so important for you. You can just go through them once. Not very important. The lateral trephination technique, again not important. It was used very early on. You can just have a look at it. What you do is basically Caldwell Look operation, you all might know or might not know. There we Caldwell Look operation mein we expose the maxilla, create a hole, a button or window, and remove the the root piece from antrum, maxillary antrum, from that hole. Same way here you also make a hole in the bone, not from top, you don't approach it from top, but you create a hole in the tooth lying area and remove the tooth from there. All these images are not very clear, but I have tried for you. You can have a look in your books, it's given better. So wound toilet, what is it? A careful wound toilet should be performed in the area under the base of the buccal flap, meaning buccal flap ke under you take your saline and your betadine and give a good thorough irrigation. It is known as wound toilet. Control of bleeding, you know how we do it. Gauze dressing saturated with bismuth or iodoform or paraffin paste. If there is excessive bleeding, you can use bone wax, you can use uh, other substances, chemical or physical, that allow us to stop bleeding. Okay. Flap repositioning and suturing. So flap is now repositioned, as so that's why your cut, your incision was more very important, because you have to reposition the flap back to how it was with minimal damage, and it has to be re-evaluated if there is any damage to the soft tissue during retraction or using your burr or any other instrument. This is followed by standard suturing and pressure packing. Okay. Interrupted sutures are given in the third molar region, not your figure of 8, simple interrupted suture. The first suture that is given is usually just distal to your second molar, and it is given very tightly so that no pocket is formed distally. Okay. Clinically, this is very important. Now the patient is given post-operative instructions that you all know about. Now coming to complications and the last part of our presentation today. So for incision, the complication can be hemorrhage, that is loss of blood, and lingual nerve damage. So you don't have to go lingually, as long as you are away from your lingual flap. your lingual nerve won't be damaged. During bone removal, injury to soft tissue, if the retraction is not possible proper, damage to your second molar, splitting of ramus in case the ramus height is very less, and you're using aggressive bone removal, and damage to bone. During elevation of tooth, fracture of tooth can be there, damage to second molar if you are using your second molar as your fulcrum, damage to ID bundle, fracture of mandible, and slipping of the tooth. One more is there which is not given here is, again I told you, dislocation of TMJ. Whenever using elevator, give support to your TMJ. Then preparation of wound. When you're preparing the wound, okay, you're cleaning out your socket, you go too deep or you apply a lot of pressure, you can end up damaging your nerves and vessels as well, okay. Complications after surgical procedure: dry socket, pain, swelling, trismus, hyposthesia. Hyposthesia is what? Not complete anesthesia, but reduced sensation in that circumscribed region. Sensitivity, loss of vitality of second molar and other tooth because of damage to nerve bundles, pocket formation, साइनस ट्रैक फॉर्मेशन, ओरोएंटल फिस्टुला, ओरोनेजल फिस्टुला, ये थोड़े आगे के हैं, ठीक है, लाइक लेटर ऑन वाले कॉम्प्लिकेशंस है, बट पेन, स्वेलिंग, ट्रिसमस आर वेरी कॉमन कॉम्प्लिकेशंस. Dry socket not so much in surgical procedures because you are giving sutures. If your sutures are proper, blood clot will not get dislodged. So here are our references. Okay, you guys being undergraduates might or might not know about references, but these are very important. Whatever you talk in your viva, whatever you write in your exam, if you know where you're writing it from, it can be a book, it can be an article, it is very important. If you write these in your exam, it gives you extra point always. Okay, that is what references are. Okay. Thank you guys. That's it for our presentation today. If you have any doubts, let's discuss them now.